Good afternoon, ladies and gentlemen. Welcome back after that break. Now it's time to resume the proceedings of the day with the valedictory session, the very significant valedictory session, ladies and gentlemen. And who better to set the context for the valedictory session than Dr. Preetha Reddy, President, NATHEALTH, and Executive Vice Chairperson, Apollo Hospitals. I'm also going to be requesting her to introduce our keynote speakers and chief guests for the valedictory address thereafter. But before I do that, I'll take the privilege of introducing her very briefly to all of you, ladies and gentlemen. Warm welcome to you, ma'am. Let me, ladies and gentlemen, introduce you to Dr. Preetha Reddy. She's, like I said, the president of NatHealth and executive vice chairperson Apollo Hospitals, a member of the founding family of Apollo Hospitals. She's widely recognized for her contributions in making very high quality healthcare accessible to millions and for her support to various entities and industry bodies working for the betterment of India. In recognition of Apollo delivering outstanding medical care during the COVID-19 outbreak, Dr. Preetha Reddy was awarded the Economic Times Businesswoman of the Year award. She was also conferred with the Healthcare Personality of the Year award by FICCI for her far-sighted vision, exemplary work, and notable contributions to the fields of healthcare and social science. A very warm welcome once again to you, ma'am. I request you to please take over the proceedings of this valedictory session. Dr. Reddy.
Namaste and thank you. And I can see Dr. Shetty here. Dr. Shetty, I'd really want to say thank you on behalf of Nat Health, all our few thousand viewers, for you taking your time off for doing this for us. The final session of this brilliant two-day summit is pivotal and critical for all of us. As we all know, data tells us, and it's a fact, that 65% of India's population are under the age of 35. So, whatever we decide, whatever is architected in these very vital sessions, are really going to impact the Bharat and the India of tomorrow. And we have some phenomenal speakers, and I really want to thank them for being there. We all know that health has been a fundamental right, it is a fundamental right. But COVID has taught us that it's actually a collective responsibility. The fault lines have been the acute lack of infrastructure, personnel, and financial resources. So, the pertinent question here is how do we work together to overcome these challenges? Public private partnerships are definitely one way to address these challenges, whether it's in the area of skilling or financing or infrastructure building. I think we need to look at ways and means to work together. It's wonderful, like the similar sessions earlier. This deliberation too has the support of brilliant minds, speakers who are really the who's who of India's healthcare landscape, and experts in the field of healthcare. We have with us, hopefully soon, the Minister for Health and Family Welfare. We have our chairman, founder, president of Nat Health, Dr. Reddy, Shri N.K. Singh ji. We have Dr. Devi Shetty with us. We have Mr. R.S. Sharma, Dr. Randeep Guleria. We can't really ask for better people to be on this panel. Um, Saying that, and going forward, I would like to really thank Dr. Shetty. There is a bio of Dr. Shetty which will be there. But apart from that, I think I personally know him. He's definitely our go-to man in a crisis. He just solved a major family patient a few days ago, and he gave it his complete time and attention. So, Dr. Shetty, I don't understand. Every human being has only 24/7, but you give each one that personal time, attention, and the way the whole system is architected, not only in Narayan Hridayalaya, but the fact that the country calls on you to give a direction for the future, whether it's in the area of skilling, whether it's in the area of financing, whether it's in the area of infrastructure building. The true architect of the future for the young of India seems to be in very capable hands, and which is yours, Dr. Shetty. So we would really like to hear from you about the skilling, which, my father, Dr. Reddy, always says this. He says, you can build a beautiful hospital, and today private equity and the banks will fund it in some way or the other, and we will find ways to do it. But what we actually need is skilled, trained manpower. And how do we find that is the challenge? Because if we don't do that, we don't have everything else. We might just end up with beautiful buildings and equipment. And also, India has the largest English speaking workforce literally in the world. So, can we really be the manpower, the knowledge provider for the rest of the world for healthcare? I think people, stalwarts like, our chairman, Dr. Reddy, Dr. Shetty, Mr. N.K. Singh, who's going to come later, all of you will give us insights into key questions like that. And having said that, I'd like to thank you once again for agreeing so readily to be part of this program. Looking forward to your comments, your directions, and the fact that these deliberations are really going to make a difference in Bharat, in India, and the young population of our country. Thank you, Dr. Shetty, and over to you.
Thank you so much, Preetha. Thanks a lot for the introduction. And you've always been a friend, what I could call as someone to bank on whenever I need something big. I'm very happy to discuss about the skilling of the manpower for healthcare. This is one topic which is close to my heart. And in the last 30 years, I've been trying hard to convince people that this is the most important part of the healthcare delivery. World Bank has predicted that in the next 11 or 12 years, there will be shortage of 80 million health workforce across the world. 80 million health workforce. Interestingly, no country in the world has plans to address this crisis, which is going to happen. Why we need to act on it today is because, unlike all the other industries where skill can be imparted in a short period of time, it takes about 14 years to train a doctor to operate on the hand, leave alone the heart. Healthcare requires intense training for a long period of time. You can't simply produce manpower when it is required. Developed countries really do not have to worry about the shortage which can happen in the future. Mainly because the moment they face the shortage, they will relax the norms for Indian doctors, Indian nurses, and Indian technicians to fly away from our country. They have done it in the past and they will do it again. I'm sure you are aware that the British government has reduced the TOEFL marks for an Indian doctor and Indian nurse to enter Britain. This is just the beginning. A lot more relaxation will happen, and as they face shortage, they will entertain more and more Indian doctors, nurses, and technicians to leave our country. And unfortunately, in India, we are not even training adequate number of doctors, nurses, and technicians for the requirement of our own country, leave alone the requirement of US and Europe. So we are just waiting for a disaster to happen with no clear action plan yet. But with the National Medical Commission taking over, which has very good people at the power center, I'm optimistic that something positive will happen. Now, where this positive should happen? First of all, we should really understand the complexity of medical, nursing, and paramedical education. Let's look at medical education. Today, it costs 600 crore rupees to set up a medical college, and it costs 140 crore rupees a year to run the medical college, so that you continue to have the accreditation by the Medical Commission of India, Medical Council of India. Now, With that kind of a infrastructure, the maximum you can train maybe 100, 200 students per year. How is it possible for us to make the medical education affordable to the the child coming from a poor family? It's simply not possible. Unless you charge crores and crores of rupees for medical education, it is simply not possible to run a viable medical education with the current norm. But next question I would like to ask is it really required for an edifice costing 600 crore rupees to train 100 doctors a year? It is not. In Caribbean region, I can buy a medical college for 10 crore rupees, which can train doctors for US. Now, how long this farce will go on? This will go on as long as we don't question. Now, I have a simple solution. All we need to do, we have about 500 medical college, about 80,000 medical seats. We can double the number of seats without spending even 1 rupee, just by doubling the number of medical students joining these medical colleges. How is it possible without diluting standards? It is possible. All these medical colleges have a 20-acre campus and they have enough classrooms. There are teachers who do not even take one class a week. So we double the number of admission, and the preclinical training program will happen in the main campus of the medical college. And for clinical, the hospital, the medical college will accredit a district hospital with about 200 to 300 beds and try to upgrade the infrastructure there with modest investment. And the moment a district hospital becomes a medical college hospital, there will be availability of the gynecologist, pediatrician, surgeon, anesthetist, radiologist, and everyone. So the district hospital or a taluka hospital will become vibrant. So we serve both purposes. One is we improve the rural healthcare by making district or a taluka hospital vibrant with all the experts. And we also double the number of medical seats in the country with hardly any additional investment. And this can be done, and I'm hopeful that the National Medical Commission will look at innovative means of producing more doctors to look after our own interests, leave alone the interest of other countries. I would like to really congratulate the National Board of Examination for a path-breaking decision they took about a year ago. This is about launching diploma courses in all the broad specialties. This will make a huge, huge difference in the outcome of healthcare across the country. There is no point in having only specialists in the hospital. We need intermediate level specialists who will take care of the patient on the bedside. And that very important component was missing in healthcare. So by recognizing any hospital with over 100 beds and senior doctors, few thousand hospitals can be converted like a postgraduate institution, training anesthetists, radiologists, pediatrician, gynecologist, all these broad specialties, we can produce intermediate level specialists. And I am 100% certain this will make a dramatic change in the way the public hospital runs in tier 2 cities. Now, coming to nursing education. If you want to start a nursing college today, you need to have a hospital. And these hospitals in private sector are generally in big towns or cities. Now, to start a nursing college, the college should own a building of 45,000 square foot. Now, all of us know what is the real estate value of a building with 45,000 square foot in a city like Bangalore. How many nursing colleges can come up in cities with this kind of a requirement. There is no other country in the world which has this kind of a rigid regulation. It is as if the regulations are made so that you cannot follow. And it goes on and on for years and years, and nothing ever happens. On the other end, we are supposed to train nurses, and with this kind of a requirement, obviously the fee for training will increase, and the girls and boys coming from poor families cannot afford these nursing colleges. So in spite of years and years of hard work and campaigning, nothing major has changed. Now, the faculty requirement. The college requirement of faculty is totally different than the hospital requirement. So with the how many competent nurses want to spend rest of their professional life only teaching rather than taking care of the patients? So all these changes has to happen. We have to change our attitude of education in medical, nursing, and paramedical. If you go to any of the organizations which are involved with education, like a university, and I will give you a simple example. If you go to any university in the country and ask them to create a curriculum to train a bus driver, they will come up with the 500-page document about the curriculum to train a bus driver. They will teach them the aerodynamics of the bus, how the fuel system, engine system will work, but they will never put him on the driver's seat and teach him how to drive the bus safely. Instead of going to a university, if I send this man to a driving school, they will not teach him about aerodynamics. They will not teach him about the engine fuel system, but they will teach him how to drive the bus safely. And this is what is required for medical, nursing, paramedical education. These education cannot happen in classrooms and universities. It has to happen on the bedside. You cannot train someone how to swim in a classroom or in a library. If you want to learn swimming, you have to get into water. After learning all the technique of swimming in a classroom, you get into water, you will drown. And that is exactly what is happening with our doctors, nurses, and technicians. We have to change. Before I finish my talk, I just want to give you one example of what we have done as a group. We do large number, as you're aware, about 14% of the heart surgery done in India is done by our group across the country. And some of our hospitals are accredited by Joint Commission of US. So if a nurse works in a joint JCI accredited hospital, they will have a preference over the other nurses who didn't. So these girls who work in our operating room, in no time, they get a job in Middle East or England or many other countries. So we end up training them for 2 years to assist us for a heart operation. And we cannot keep on training every time. We need somebody who's trained and who stays with us. But if a nurse got a BSc degree, she is not going to stay with us. So we started identifying girls who couldn't get into nursing school or a nursing college because they had no money. And we enrolled them under a program called CCA, Critical Care Assistant. And we trained them exactly like a nurse is trained. But these nurses are trained only to assist for a heart operation or a brain operation or a specific operation. Now, when they finish the training after 3 years, today most of the girls who are assisting us are our own products of CCA. When I put my hand and ask these girls, if I ask them to give me a 6-O prolin, this girl knows that the step of the operation I am in, I need 7-O prolin, not 6-O. So she will give me 7-O prolin, but she won't say anything. She gives me what I need rather than what I ask for. This is the level of smartness, alertness, and the knowledge they have, but they don't have a BSc degree. Now, we need to really look at for specific complex tasks in healthcare, can we train girls and boys who are trained only for that particular task? We are not looking at a cheap labor. Don't get me wrong. We pay our CCAs exactly like a nurse. But our idea is that they will stay with us and train the younger generation of nurses who are coming to us so that our surgeries go on safely. So this is the power of training. And this training can be only given in hospitals. So we all should relook at the way we think about a hospital. Of course, hospital is the place where people in pain or sickness are taken care of. But we need to really look at how this hospital can become an edifice for training the skilled manpower for the future so that our country will be safe and secure in the years to come. Thank you so much, Preetha, for the opportunity. I'm extremely grateful to all of you.
So I think I need some training on specifics, just like the girls in the OR have been trained. But having said that, Dr. Shetty, I think we need a new way of looking at things, and I think that is the way for the future because we've got a whole workforce which needs to be trained. We've got a young population who has to be occupied. We also have an aging population who we have to finance healthcare for. So I think, there are multiple challenges. And what you've given us in terms of advice that focus on skilling, looking at it in a completely different way, has been extremely rewarding. I had just one question before, we move on to Sri N.K. Singh ji, who I can see on the screen, is that, it seems like we really need to change mindset in terms of, the nursing colleges, or if we have joint commission, the BSc nurses. Are there any specific one or two steps which, we maybe as Nat Health or the government working together with them, is there anything in specific in terms of an intervention we really need to do?
See, Preetha, what is important is the legal entity which conducts the educational program. It has to be a not-for-profit. Okay. Now, for companies, creating a not-for-profit is a bit difficult. It has to be a trust. Okay, we will create one. But this should own the assets. Now, we own the hospital. How can we give the assets of the hospital to a trust? It is not possible. And the trust has no money to acquire those assets to conduct the training program. So these are the issues which the educational institution should not insist on asset of the building, real estate to be owned by it. It can be leased or it can be rented. So this is a very, very important component. And the other one is the faculty. Faculty should be able to work in the hospital as well as in the education institution. And that is the only way you will get the best faculty.
Thank you, Dr. Shetty. I think that's like, perfect advice. And it just makes me feel like there's so much more to be done. But having said that, over the years with stalwarts like all of you, our country has truly become a global power in the healthcare space. And I'd like to thank you for that and thank you for the time. And hopefully going forward, a lot of your dreams, our chairman, Dr. Reddy's, and multiple people like you, all your dreams will come true because there is so much to be done for Bharat in India. Thank you so much for your time. Our next speaker, ladies and gentlemen, is none other than Sri N.K. Singh ji. He has been a friend, philosopher, and guide in multiple ways. And having said that, he's got the most amazing bio, which has been put in front of you. The biodata is there. But more than anything else, Chairman Finance Commission of India, and a topic where we will say more money for health versus more health for the money spent seem just so apt because he has emphasized on multiple times a greater role for public-private partnerships, working relationships to ramp up health infrastructure. He has also stressed to scale up public spending on health from a 0.95% of GDP to 2.5% by the year 2024. And I think that is an amazing forward-thinking view. He's also said that the Finance Commission has and does need to support and advocate the public-private partnership models in Indian healthcare, where all components come together, whether it's the state, the ministry, research organizations, and we should build a robust healthcare sector together. And at that point, when we talk about public-private partnership, I think the financing comes into play because, you know, in our mind, there's always a worry about how do we finance healthcare? Is it a responsibility of just the private sector? Is it the responsibility of public sector? We've got Atmanirbhar Bharat, we've got Ayushman Bharat. How can all this come together as a beautiful orchestrated future program and plan for us? I think that would really be wonderful for India. And as I've repeatedly been saying, that whatever all of you say, think, decide, help us do, is where the future of Bharat lies. So again, N.K. Singh ji, thank you so much for giving us your time. I completely understand the constraints of, the amount of work which you do, and you've still given us 20 minutes and research so much in the background. I read all the documents which you so kindly sent us, and it's not easy to do that. So I truly appreciate your time, your effort, and your energy. And over to you, sir, and thank you again.
Well, thank you very much. Thank you, Preetha, for this opportunity to speak to the 7th National Summit on National Health. I must begin by first requesting you to kindly convey my best wishes to your revered father, a very dear friend of mine, whom, as you know, I have known over decades, and our mutual warmth and affection has endured over decades. Second, since I see in front of me, I see very distinctly in front of me, Devi, let me also say that you said some nice things about the Finance Commission. Well, Devi was instrumental as a very important player. Some of the unconventional ideas which he came out with toward the end of his remarks today is quintessential Devi. He had put forward many unconventional ideas to the Finance Commission, some of which I'm very happy to say that he knows we have adopted in our recommendations. But today's theme, you want me to speak for 20 minutes, and I'll confine myself to that, on how can India balance the need for more money for health versus more health for money. Well, as we know that Hippocrates, the wise man, had said that any person should consider that health is the greatest human blessings and learn how, by his own thought, to derive benefits from his illness. You understand that this Hippocrates' famous quote entails upon us the responsibilities and obligations as physicians and health practitioners, those of you who are there, and I have sometimes wondered if this quotation attributed to him is without any relationship to concomitant social obligations. Hippocrates asked us to perform some of these responsibilities, duties, and obligations. He left out the expectations from the societal order. The two need to work in tandem, his oath and the societal order. The theme of today's lecture brings out the asymmetry, if not the contradictions, between additional money and better health outcomes. Balancing is an obvious thing to do. However, it is never easy to balance, far less balance perfectly. One must therefore strive to work some at least suboptimal solutions and symmetry for the forward path. For instance, it would be no-brainer, and Devi knows this very well, that even within the limited resources, there could be concerted efforts to reduce the sharp incidence of regional inequality, ensuring minimum access across levels of health systems, and also re-examine our expenditure priorities. A better way, therefore, to rephrase today's subject would be, how can India optimize improved symmetry between better health outlays and better health outcomes. There are some obvious and notable gains, which we all know we have made in the sphere of health. Our life expectancy has gone up close to now 70 years, has crept up each year. There has been decisive progress in infant mortality, in death rates, in multiple health parameters. And health remains one of the most unreformed areas, if I may say so, notwithstanding the great efforts which have been made in the last few years. Literature is replete from comments from domain experts on the need for better health care, and eminent economists such as Joseph Stiglitz, a good friend of mine whose lessons also have taken, has said that healthcare is very different from other sectors of the economy in several aspects, one of which is the fact that the risk can be very much beyond people's ability to pay. I think that Joe has summed up this quite well. Similarly, Christine Lagarde, my good friend, currently the head of the European Central Bank, has said that without decisive policy actions, pensions, and more importantly, health systems will become unsustainable in just a few decades' time. The challenges are multiple, which you know: inefficient funding, shortcomings in the quality of care, neglect of urban health, inadequate number of health personnel, and other serious disabilities, including the lack of concern and priority more than concern to the rural health system. This is worrisome, considering, and this is an aspect on which Devi knows this very well, this is worrisome because given the pandemic, the out-of-pocket expenses on health, which we know has crept up to now 70%. This is completely misaligned with the out-of-pocket expenses on the health sector for most countries. We also need to understand that these out-of-pocket expenses pose serious risks and uncertainties in pushing people back into poverty, particularly those who are living at the critical margins of the poverty line. The international experience of the healthcare has shown an increasing awareness to improve the healthcare system. Nonetheless, if I ask myself the question, have regional cross-country experiences, have inter-regional heterogeneity and divergences increased? Regrettably, the answer may turn out and will turn out to be a positive one. The cross-country average health indicators on per capita basis shows us down as among lower than some of our peer group countries like the Bangladesh and some other examples in the neighborhood. So there are these very important issues. The World Bank, for instance, has estimated, and Devi has pointed this out earlier, but I would like to repeat this, they have estimated that 150 million people will be pushed back into extreme poverty by 2021, post-pandemic, which means much longer repair time for the global health systems and therefore the consequences upon us. The consequence of all this is reflected in multiple ways. First and foremost, on the subject we mentioned, namely the poor health outlays. Now, this poor health outlays, we know that notwithstanding all efforts, it has still hung around only 1% of GDP, contributed both by center and the states. I must say that the budget of 2022, which you would have focused on, has highlighted not only health as an important sector, but has demonstrated this in a somewhat unprecedented way. Most importantly, it recognized the interlinkages of health with nutrition, with water, with sanitation facilities that reinforce each other. Allocation for the health and the wellness sector increased mainly on account of the increase of allocation on water and sanitation, which increased from 21,000 crore to 60,000 crore and for 35,000 crore for the post-COVID vaccination. These are besides the Finance Commission grants which I gave. The Finance Commission grants were given had two components. The first related to strengthening the third tier of the health sector, for which we had given 70,000 crores directly to the third tier, and this is under implementation because the central government has fully accepted this recommendation. The balance of 30,000 crores, on which Devi and we had worked together, is also being worked upon and will be considered within the framework of a rationalization of the centrally sponsored schemes. Taken together, These constitute a major thrust, both in the engagement of government at multiple levels with the health sector initiatives. It augments for much higher outlays. There are other government initiatives which are contained in my speech and which I'll request you to kindly circulate, which I have highlighted there. I come to some important aspects. One is enhancing the role of the third tier in the health sector. When Devi and I have discussed this informally in the Special Task Force in the health sector, we were convinced that as the Finance Commission, we must recognize that public health forms part of the 11th and the 12th schedule of the Constitution, which necessitates the engagement of the third tier of government. The National Rural Health Mission provides for the implementation of the healthcare programs through a decentralized system with the involvement of the local governments and community. In fact, the local government play a critical role in the planning and the implementation of monitoring the NRHM. The 11th plan similarly emphasized the need for greater involvement of the local government institutions. The 12th plan did so equally. There are, unfortunately, in the past, all the initiatives had remained underfunded. We wanted to cut this Gordian knot. So what we did was we adopted a somewhat unconventional approach, that money we assigned to the third tier directly, without this going through any ministry, without this going any way to the state governments, and we assigned this money of 70,000 crores, apart from other things for which you've assigned, these 70,000 crores are assigned for just 5 staff. Support for diagnostic infrastructure for primary health centers, block level public health units, urban health and wellness centers, building less sub-centers of primary health centers and community health centers, and conversion of primary health centers into sub-centers into health and wellness centers. The 70,000 crore are allocated across these 5 important obligations, which relate to the rural health sector directly. This, of course, is in addition to something which we did on additional provisions for air and water pollution and improvement of other pandemic-related vulnerabilities. But as we go forward, there are some critical issues which we need to be addressed. First and foremost, a clear recognition, which the budget has reiterated, that public outlays in the area of health need to be substantially enhanced from 0.9% of GDP to 2.5% by 2025. Indeed, this is a program laid down in the health policy of 2017. This is notwithstanding not only what the health policy of 2017 said, but even earlier commitments which were made in relation to the health sector. Second, the issue of large interstate variations in terms of health funding and health outcomes. All states, except Meghalaya, are spending less than 8% of their budget on the health sector, with the average being around 5.18 in 2018-19. The interstate variations on the ratio of doctors and nurses and life expectancy have a very wide spectrum. Let us say 65 years in Uttar Pradesh, it's over 76% in Kerala. Or for instance, in states like Tamil Nadu and Kerala, the total fertility rate is just 1.59 and 1.79, whereas the TFR in the case of Bihar is significantly close to 2.93%, which at Uttar Pradesh, 2.61%. Similarly, in respect of the infant mortality rate. The third important aspect is the issue of the regulatory framework for the health sector. Regulation of the health sector for quality, standards of care, assessments of services, hospitals, and accountability is crucial for the health sector. Some of the issues relate to the health spending by the states, which needs to be increased more than 8% of their budget in a short period of time. We have indicated a program based on that. Also to consider and provide for evidence-based guidance in relation to setting down quality health standards and provide information to stakeholders involved in the healthcare system and a national institute. And we have suggested the establishment of a National Institute of Health and Care Excellence on the patterns of the United Kingdom. Fourth, This is something which you mentioned in your remarks. Health is not a part of the concurrent list under the Constitution. So, whereas legislations have been enacted, they have been enacted on a subject which remains integral to a state list. In the light of the pandemic, is it not high time that we should consider moving the health sector as part of the concurrent list? The right to health would, in course of time, form congruent with overall directives and spirits of the Constitution. But to begin with, at least, should we not, without going very far, making health a fundamental right, should we not consider making health part of the concurrent list, which would then have an enormous obligation, the burden sharing among all stakeholders? It would also give the central government more flexibility in the enactment of multiple regulatory changes. Fifth, the health sector is in dire need of a health development financial institution. The budget of 2022 mentions the setting up of a DFI to stimulate investments with an initial corpus of 20,000 crore. The need for the health sector specific DFI is much needed on the same lines as that of a DFI which I have just mentioned. There are many DFI entities which are engaged in the health sector. Such a DFI could increase the healthcare concerns in Tier 2 and Tier 3 cities and also come up with technical assistance that ensures proper usage of funds. Sixth, there are several other medical services, such as dentistry and pharmacists, which come under the purview of different laws, rules, and regulations. There is a multiplicity of acts, rules, and regulations, and the mushrooming of institutions. Yet, the regulation of the sector is far from adequate. There needs to be a rationalization, streamlining all these rules, regulations, and institutions. The multiplicity of acts covers both the central government and the state government. There is a huge asymmetry between them. There is need to have a standardization of healthcare codes for both the center and the states. We need a uniform healthcare code, HCC, entailing both health ecosystems of the central and the state government. This has been done recently in the case of the Securities Market Code. 7, the universalization of the healthcare insurance system. Now, we have gone through what huge changes the PMJSY has brought about. But we look at the broadening of that to truly universalize the healthcare insurance system based on the experience which we have gathered so far of the working of this difficult project of PMJSY. 8, enhancing and ensuring high quality of medical and health personnel. There are some obvious suggestions. First, given the interstate disparity in the availability of medical doctors, would it not be useful to constitute an all-India medical and health service as envisaged under Section 2A of the All India Services Act of 1951? Second, the MBBS curriculum should be restructured to make it competency-based. A certain degree of specialization should be included in the curriculum, and the Medical Council of India, or the National Medical Council which exists now, to develop small courses on wellness, clinic, basic surgical procedure, anesthesia, gynecology, ENT, to give an example. It could also encourage Ayush as an elective subject for medical undergraduates. Connected with this is the asymmetric distribution of medical colleges, which needs to be corrected. All India public health facilities, including direct hospitals, private sector facilities included, and corporate hospitals, should be utilized for starting specialized D&D courses, which will not only enhance the service commissioning, but will also ensure the availability of turned human personnel. The patent right to this suggestion goes to Devi. I go on to say that there is need to utilize the foreign medical degree holders in the health system of the country to supplement the existing human resources for health. This may be done by designing a skill-based training program to improve their knowledge and skills so that they meet the professional competencies and required in the screening tests before commencing the practice in the country. Then measures should be taken to assign a greater role for nursing professionals. The concept of a nurse practitioner, physician and assistant, and nurse anesthetist should be introduced for better utilization of nursing professionals. The budget of 22 mentions the introduction of the Allied Services Bill, and which has been introduced for some time, including areas like nursing and midwifery. In fact, I think that we have pursued this relentlessly in the task force, and I'm happy to say that you would have noticed, Preetha, that just on 16th March, the Rajya Sabha did enact the National Commission for Allied and Healthcare Professional Bills to 2021, which seeks to set up a commission to regulate the allied healthcare sector, standardize training and qualifications across the country. I have dealt with this in the recent Finance Commission report, where we found one interesting thing, something that the task force had also come up, that there can be no greater proportionality, no greater relationship in the proportionality between expenditure outlays and outcomes, except in the case of the allied health sector. The allied health sector undertaken training of nurses and their workers, district levels, will dramatically alter the availability of human personnel. In its report, the Finance Commission has therefore recommended 13,296 crores for the training of allied health workers and workforce, which will help in creating and generating employment opportunities. In conclusion, our success in addressing these issues and the process also of addressing some of the key challenges which we confront. The holistic approach to the healthcare strategy must include these measures undertaken in an integrated way. One cannot work without being in symmetry with the other. Debilitating rules, procedures, and measures would mitigate against the better outcome from enhanced health outlays. At the same time, they would not yield the required and desired outcome if you are looking at a symmetry between outlays and outcomes. India needs to address this not only to mitigate impact of the ongoing pandemic, mitigate the impact of neglect of the healthcare sector over decades, but we owe it also as a member and a respectable member and a member in standing of the international community. India is a home now. The important vaccine initiative, which have been applauded globally. India has not played vaccine politics, nor converted vaccine into geopolitics. But in a non-political way, it has sought to address the human altruistic compulsions created by the pandemic. We need to build on these initiatives, fully extract the goodwill which we have demonstrated. Let's end with a little quote I often read from Swami Vivekananda when he said, "You must keep a strict eye on your health, that everything else be subordinate to that." We must keep a strict eye on the health of India, the health infrastructure of India. Thank you very much, Devi, for this great opportunity to be able to share my thoughts with you. And thank you, Devi, for sparing the time of being with us here today.
How does one say thank you to Shri N.K. Singh ji? You know, it was just an amazing rendition of what has to be done in our country and the healthcare landscape. But more than anything else, you know, on behalf of NATHEALTH, I really want to say this, that NATHEALTH set out to be, you know, to be a thought leader. It's only a 7-year-old organization. And at some point, we also said that we want to be the Brookings of healthcare. This document, which has been put together and which has been rendered in his just impeccable English and diction, I think is really a valuable document, not only for us, but for the future of India's healthcare. And I would really look forward to, you know, some bright and interactive just working together. And I see that Dr. Shetty and NK Singh ji did a lot of work together. I'm not sure if Mr. NK Singh is still on the call, but Dr. Shetty, I really want to ask you, there was so much put together in this document and the way he articulated what needed to be done. And you said these are the few steps which we have to do. Health is still, there's a national budget and the center allocates an X amount to the states. And some of the states who really want to do a lot, they pick it up and they do and they deliver. And there's some other states, and we saw the healthcare indices there, and they don't do as much. Is there a way where we can, literally make states pick up? Because I don't think it's about the money or the allocation. There is still some amount of money or finances left. How can we bring the level up to some states? There's such a big disparity, and it's sad, and I don't want to be short for this, but the southern states seem to be doing, so much better in multiple fronts than some of central India or remote India. Is there something we can do to focus so that the level just goes up?
Preetha, everything depends on the leadership in a particular state. There are quite often we find very, very progressive ministers and bureaucrats who are very keen to make something happen, and the other way around. So unless they approach asking for help, we volunteering, in my experience, really doesn't make a big impact, but there is nothing wrong in trying. Definitely nothing wrong in trying.
I completely agree. And some of the comments which Sri N.K. Singh ji made, there is this whole thing about the future of India, and a lot depends on the NCDs. How do we really combat that problem? Like we're saying COVID, and then we spoke about vaccines, and we've done all that, and I'm so proud to be an Indian. But the onset of the NCDs now seems to be a really scary issue. So what do you think about that?
See, the country really requires huge skilled manpower. Without the skilled manpower, we won't be able to manage NCDs. As you know, NCD specialty requires very, very specially skilled people, which we are desperately short. I think the manpower, then the health insurance to pay for the care, because expecting the government to pay for everyone's health care is not going to happen. So these are the two issues. One is the group of people to take care, and the other is a financial intermediary. Financial intermediary, we have to really change the concept of health insurance in the country. We should really go for the managed care model like Kaiser Permanent. The entity should collect the money from the citizens, and they should strive for 1 year to make sure that the person doesn't fall sick. So that is the best business opportunity option for the patient and the hospital. Like today, if we really want our business to prosper, we should pray to God for everyone to fall sick, and that is not good for the patient. Instead, if people keeping healthy is the best way for us to make money, then it is good for the patient and good for us as well. Yeah.
I totally agree on that because, when our chairman speaks to us, he now tells us, give me a model where we keep people out of hospitals. Because literally there's only this many hospital beds you do, and they're getting filled up regardless. Where we feel really sad and, disappointed that if somebody came in early into a hospital system, you can detect it early, keep him well, and literally keep him away from number one, financial disaster, and personal and healthcare disaster. So I think, really speaking, there's a lot for all of us to do, and the planning, the inputs which come from stalwarts like all of you, I think has been such valuable advice. Uh, I just wanted to say on this that, in Chittoor, we actually have done a very successful model of, of healthcare. and where we have the medical school, like you both of you advised. We've taken the district hospital. When we started, the footfalls were around 500. Today, they're about 4,000, upwards of 4,000. But more than anything else, during the COVID time, the interventions and the outcomes were on par with some of the best hospitals within the city. So I think this is a replicable model, and it is very, very useful to us. But having said that, NK Singh ji, for us, we represent as a group the private sector healthcare, and I think we're one entity which really wants to work together with the public sector, with the governments. So just give us like three things which you think we really have to do to get all this vision of yours in this 19-page, very valuably well put together document. What are the three things you think we should do?
Thank you very much. Daunting challenge, but I wouldn't inflict a 19-page note on you again. But let me give it a few days and make some thoughts to send you and to Devi an email of some suggestions. Thank you very much.
Thank you, sir, because I really understand to put together such a valuable document is truly architecting the future of our young generation. It's going to be beyond our time. And that's why I think the time, energy spent, the effort put in by both of you has been so valuable. Thank you again for your time. And I'm looking forward to more advice for Nat Health to grow in the future. So thank you.